Welcome. My name is Vicki Evans. I'm the Regional Director with Seniors Blue Book. Welcome to our Seniors Blue Book University event. We're doing this via Zoom, as many in the world are, but hope to one day return to live and in-person Seniors Blue Book Universities because they're very, very beneficial. I'd like to introduce my community liaison, Lisa Case. Lisa.
Good morning, everybody. I'm Lisa Case. And I just want to say good morning. Thank you guys for attending. I'm looking forward to hearing this myself, so I'm sure there's going to be a lot of great information for us all. Once Beth starts speaking, I am just going to be in the background and we are going to be watching for your questions. Beth has a presentation that she's going to go through first, and but you will be able to put your questions in the Q&A. Excuse me, I'm going to have to cough. I'm so sorry. You're going to be able to put your questions in the Q&A. I see that some have already put them in the chat, and that's fine, but we are going to be watching for the Q&A. So please try to utilize that if you can. And at the end of Beth's presentation, we're going to open it up and take those questions, and Randy will be the one to help Beth go through those questions and answer them. So thank you guys. Thank you for attending, and enjoy the presentation. And Nancy?
Appreciate your time. Nancy, our illustrious publisher. Nancy, please introduce yourself and talk a little bit about your life with Seniors Blue Book.
Yeah. Thanks, Vicki, and thanks everybody for coming. I'm going to duplicate Lisa's sentiments. I'm really looking forward to the presentation today. So Beth, thank you, and Randy, thank you both for everything you do and for being willing to share your expertise with us. So yes, I'm the publisher of the Seniors Blue Book. We have 7 editions in the state of Colorado. You know, as we all navigate this new normal, we don't know what that's going to look like as 2021 comes around, but the Seniors Blue Book has been busier than ever. We have just done nothing but expand our reach and offering all different ways that our partner advertisers and also the seniors and the caretakers that utilize our book can enhance, you know, the things that we've done to enhance that for them. So a series like this is right in line with what we're talking about. So just really, really happy to see everybody on the call and looking forward to today's presentation. Thanks.
Nancy, appreciate it. I am going to introduce our facilitator today, and his name is Randy Bulow with Oasis Senior Advisors. And when we were brainstorming on ways to reach audience and topics that would benefit many, Randy offered this topic for us and this author, Beth, that's going to speak today. So I would like to say hello, Randy, and please take it from here. Tell us a little bit about Oasis.
Well, thank you so much, Vicki and Nancy and Lisa. It's great to be a part of Seniors Blue Book University. And I want to thank everyone for joining us for this practical session this morning. By way of introduction of Beth, you may know or have read that she's a registered nurse, a certified Alzheimer's disease and dementia care trainer, a certified senior advisors. But what you likely don't know is that my story intersects with Beth on a very personal and professional level. See, my mother has suffered with dementia for over a decade, but as you know, with dementia, there are those who are afflicted and those who are affected. Both parties need support and guidance. And this was certainly true for my family in Nebraska at the time. When it was time to move Mom from her home with 24-hour in-home care into a memory care community in Nebraska, we discovered Beth and Oasis. Well, the education, reassurance, and expertise that Beth offered was so pivotal in our journey. Not only did Beth find the perfect community for Mom and her beloved dog, but it also inspired a change of careers for me to become an Oasis senior advisor and owner here in the greater Denver metro area. It's also why I'm so passionate about Beth's book and getting anyone and everyone to understand more about this tragic disease. And I'm offering this book for no cost or obligation for anyone that will send me an email. You can find my email in the chat, and I'll reference it here in a bit. it's a great resource, as you'll find, as she talks about it. Perfect guide, a small guide, 80 pages, for either you, your family, or your patient's family if you're a caseworker. You know, there's such misunderstanding about dementia that anyone or anything that we can do to educate people will bring earlier support and comfort for families dealing with this disease. Now, Lisa, if you want to bring up the slides, there are a few ways that you can learn about OASIS Senior Advisors, and I'd be remiss if I didn't mention Seniors Blue Book. If you're an individual who needs support, you may have seen my story in our ad in the Seniors Blue Book, North Metro Denver, or soon to be in the Boulder County area. And then if you're a case director, manager, or social worker, you may have seen our ad in the Seniors Blue Book Discharge Planners Resource Notebook. So though we are a free referral placement service to seniors and families, we are happy to help with the transition with your patients to the next appropriate level of care. We are certified senior advisors, members of the Greater Denver Professional Referral Alliance, and we have teams supporting the entire Front Range. So with that, it's my pleasure to introduce Beth Friesen. Beth?
Thank you so much, Randy. Do appreciate that. That was your words just about how our lives intersected a little over a year ago is pretty cool. So it's indeed an honor to be with all of you today. And this is obviously a subject I'm very passionate about and enjoy teaching on. And so I'm going to start now, if it's all right. I'm going to start sharing my screen here. We will start the slideshow. And hopefully you can all see that just fine, because in sharing my screen like this, I can no longer see you. So Randy or somebody's going to have to speak up if you can't see the slideshow, because there's no way I can tell. But this is the book, I Love Someone with Dementia, So Why Am I Losing My Mind? That I wrote well, I guess it came out a little over a year ago. And it's a very personal story, very much based on what I and my family learned throughout our journey with my mother, who had Alzheimer's dementia. And when I provided a copy to my dad right after it was published, he took it home. He read it that evening. It is a fairly short read. He read it that evening. And yes, my 90-year-old father.
Excuse me, Beth. I'm so sorry to interrupt, but we have comments that we can't see your screen.
Uh-oh.
That we
cannot see your screen, Beth.
Okay. Let's see. I bet I know why. Hold on a sec here. I think this will help. Let's try this.
Yes.
That should be much better.
It works great. Thank you, Beth.
So sorry, you guys. There we go. Still seeing it okay?
Yes.
Yes,
Okay.
indeed. Perfect.
All right. Fantastic. So I apologize. So when I provided a copy to my dad, he texted me. Yes, my 90-year-old father texts, which I think is kind of cool. And he said, where was this book 10 years ago? And I responded with, exactly. And that's why I wrote it. So that was I knew I had done what I had set out to do with that response from my dad, because that is what we were after with it. So of course, any good university presentation, we've got to have some objectives here today. So what we want to do today is increase your confidence in identifying the suspected presence of dementia. Let me clarify that just a little bit. We're not out here to diagnose it. We will leave those things to the experts. But when you have a gut feeling that something is going on, this will hopefully give you an increased confidence then to take action on that. So what will help in that process is to increase your understanding of the most common forms of dementia out there. The more we understand about the disease, the better able we are to get a handle on something's not quite right here. And then once we have that going, then help us to better understand how to equip the families we work with to get a diagnosis, and then successfully navigate this journey a little bit better. So let's start at the beginning and with some basics. And I know that my audience is very broad today, and I know for some of you, you know this all inside and out, and for others of you, this may be some newer information. So I'm trying to hit that nice middle road here. Hopefully we'll do a good job with that. But dementia is an umbrella term, if you will, which encompasses more than 90 different types of dementia. That number is staggering to think that there are 90 different forms. Alzheimer's is the most common of those. About 66% of all dementias are of the Alzheimer's type. What is dementia versus normal cognitive decline? As we age, we all experience what we call normal cognitive decline. We see this especially in things that involve multitasking, which is one of the reasons driving becomes more difficult as people age. But that is not dementia. Normal cognitive decline will usually allow the person to arrive at the correct decision or at the correct answer. There just may need to be some additional processing time allowed for that to happen. With dementia, our hallmark sign is our loss of executive function. What I mean by executive function, and what the experts mean by that, is when preparing a recipe. Let's use that as an example. When we're going to make something in our kitchen, we first have to look at the recipe. We have to decide, do I have all the ingredients on hand to make this recipe? If I don't, what ingredients do I need to purchase at the store? Making a list of those ingredients, either mentally or on paper. Going to the store, buying the right ingredients. Now coming home, and then following a sequential pattern of steps that need to be done to follow that recipe and have it turn out, hopefully a little bit, at least like the picture on Pinterest would indicate. We don't always succeed, but I think you know what I mean in that. When we have a loss of executive function, we can no longer follow those steps to create a series of events that result in a finished product that we're looking for. So why this happens is because the brain literally is changing its structure and its size and ability to function as it once did. Therefore, the person with dementia is often prevented from understanding that they have the disease by the very nature of the disease itself. And I think this is one of the saddest ironies of dementia. I like to use the example, if you have heart failure and you walk to the top of a staircase and you are out of breath, you fully understand why. With dementia, the very nature of the disease itself prevents you from understanding why you can no longer perform the way you once did. Usually fatal, dementias eventually render the individual in a childlike state requiring 24-hour care. So here's some of the more common types of dementia. We're going to focus on a few of those today. Alzheimer's, Lewy body, vascular, and frontal temporal lobe will be the ones we look at a little closer today. We also see a fair amount of alcoholic dementia and mixed dementias. And that's when we have more than one thing coming into play. So for instance, an individual could have Alzheimer's dementia and some alcoholic dementia as well going on at the same time. So let's take a look at Alzheimer's here a little bit. What does this look like when we see it? Well, when meeting with a family, when their loved one has dementia, Alzheimer's, it may sound a little bit like this. I know their memory isn't as good as it used to be. She repeats herself a lot, but her long-term memory, it's great. She knows everything from her childhood. Some days he can hardly remember anything, but then I talk to him on the phone the next day and he seems fine. Dad's forgetting to pay his bills. Showed up at the bank. He didn't remember why he was there, but his memory is fine. He knows who I am, right? I've heard that one a lot. And then we also often have some personality changes. She's gotten really nasty. She's become kind of reclusive, won't go out, but she's really healthy and she can get around just fine. Now, when we're meeting with a patient, these are some of the things we may find. They may have advanced dementia and still be completely socially appropriate. And that's because those social norms that have been ingrained in us since we were tiny kids come into play there. Their clothes could be stained or mismatched. There may be significant and dangerous hoarding going on. They might fidget with a zipper or a button. Their answers to questions may lack specificity. I call them canned responses. So it's a very generic response so for instance, you might say, well, Margaret, did your kids come and visit you yesterday? Oh, they're so busy, and I'm so busy. I can't remember from one day to the next if they were here or not. Very canned, lacks that specificity. You might find they have a loop time. So after about 20 minutes, they may start repeating all the same stories again. Do ask about their medical history, especially if you already know it. That may give you some very significant insight. If their family member is there, especially a spouse, they may start to answer a question and then look to the family member to fill in the gaps. See that quite often. Or ask, how did you come to be here with us in our rehab or in our hospital? And see what they say. There are 7 stages of Alzheimer's dementia. Not every form of dementia can be packaged, so to speak, in these nice little stages. But I think it gives you some help in understanding dementia, but specifically Alzheimer's. There are different stagings out there. Some like to use a 5-stage, some use a 3. I personally really prefer Dr. Reisberg and her 7-stage because I think it makes it easier to quantify for us. But just briefly, stage 1 is no impairment at all. No one knows, including the person with dementia, that they have dementia. Absolutely no impairment. But on autopsies of people who have died in car accidents and things like that, we have seen the beginnings of the plaques and the tangles that are the hallmark of finding inside the brain of someone with Alzheimer's disease. Stage 2 is very mild decline. All memory tests at this point are still normal. Family and friends have no idea anything's going on, but the person with dementia may start to notice some things that really frustrate them. I remember one Easter Sunday after a big dinner that my mom had put together. She came into the kitchen and she just was poking at her forehead and she said, "Why can't I remember anything?" Now, when we look back, we really believe that our mom was in stage 2 of Alzheimer's at that point. Stage 3, mild decline. Friends and family are starting to notice maybe something might be not quite right, but it can be very transient at this point. They can do just fine. One hour and the next hour they're fumbling trying to find a word or remember a name. Moderate decline is where now it is very apparent to everyone almost all the time. They may not know their phone number, address. They can get lost easily. Sundowning, if you're familiar with that term, which is a term that we use to describe the worsening of symptoms in the late afternoon and evening hours, becomes very prominent sometimes in stage 4. Stage 5 is moderately severe decline, and we really categorize this as being the stage in which bowel and bladder functions really start to go, become very unpredictable. They may be incontinent of one or both. They may have times a day or certain days where that is fine. But usually if someone tells me that bowel and bladder function are starting to suffer, I pretty much know right away that they're probably in about stage 5. The cognitive abilities of a stage 5 person is generally going to be somewhere between 8 and 10 years of age. So you can see why but I should go back just here for a second. In stage 4, we're talking pre-adolescent. in their cognitive abilities. So in stage 4 and 5, we can really start to see how these folks should not be left alone. We can't imagine allowing a 10-year-old to live on their own, let alone a 10-year-old that cannot remember if they have eaten lunch. So it becomes so important that they have round-the-clock care at this point. Stage 6, severe decline. They are helpless and dependent on you for everything: dressing, bathing, eating, drinking. You could set food in front of them or something to drink, and there is a good chance they wouldn't know what to do with it at that point. Stage 7 signals impending death. At this point, they are often bedridden, they cannot walk, cannot talk, and their journey through this disease is obviously coming to an end. Lewy body dementia. This is the second or third, depending on which statistic you look at, the most common form of dementia. And there are 3 forms of Lewy body disease. There's Parkinson's, which is a form of a Lewy body disease. And you can have Parkinson's without dementia. You can have Lewy body dementia, or you can have Parkinson's dementia. I'm going backwards instead of forwards. What's happening here? There we go. That's better. So we do need to be able to distinguish between Lewy body dementia and Parkinson's dementia, and that really requires some good detective work. So Lewy body dementia is dementia that occurs before or at the onset of Parkinsonianism. So basically almost at the same time or within a few months. However, Parkinson's dementia is dementia that occurs 12 months or longer after the development of Parkinson's disease. So all 3 of these, they find that they have Lewy bodies present in the brain on autopsy, okay? But you can have Parkinson's disease and not develop Parkinson's dementia. In fact, about 30% of Parkinson's patients will go on to develop Parkinson's dementia. And it is postulated that Parkinson's disease is an autoimmune disorder. And that's an inflammatory response that results from the accumulation of Lewy bodies in the brain. So Lewy body dementia will contain a classic triad of symptoms. Fluctuating cognitive impairment. So this is going to fluctuate more than someone with Alzheimer's dementia. Visual hallucinations are very present and very concerning for families and the patient in Lewy body dementia, as well as extrapyramidal features. And extrapyramidal features are what you think of with the classic Parkinson's patient, but it's also going to occur in Lewy body dementia as well. Like I said, their progressive cognitive decline will occur, but it's going to fluctuate more than Alzheimer's, particularly with attention and alertness. So these folks tend to fall asleep a little bit easier during a conversation or something like that. Also, because of the Lewy bodies, you're going to see a few more falls, which is obviously something we really need to take into consideration and be concerned about in regard to their safety. And you will also see more depression in a Lewy body dementia sufferer. And so this is something we really need to be cautious about, because don't mistake dementia for depression. So, and vice versa. So that's something, you know, that you need to have a trained medical professional take a look at to make sure that it's not one over the other. Frontal temporal lobe dementia is found in a younger segment of a population generally. It affects only the frontal and temporal lobes of the brain. So here we got the frontal lobe, here we've got the temporal lobe. And this is visible on scans. So the rest of the brain will be a totally normal size and shape on the scan, but the front and temporal lobe, those lobes will be visibly smaller on the scan, and it's almost always asymmetrical. And by that, I mean either the left side or the right side will be more shrunken, and visibly you can see that on the scans. It's quite something. Now, which lobe, right versus left, is most affected, as well as frontal versus temporal, will determine the 4 variants that are associated with the disease. We're not going to get into the weeds on all of that, but what you can know from that is which lobe is affected is going to tell us if it's more of a language issue that comes up for these patients or more of a social conduct disorder that comes up for these patients. Often with frontal temporal lobe, they also have motor skills that are affected. And the more motor skills are affected, it will shorten their life expectancy. So if you see a frontal temporal lobe dementia patient with a lot of motor skills that have been affected by the disease, their life expectancy is going to be shorter than someone who doesn't have that associated with it as much. Frontal temporal lobe is also closely related to other neurodegenerative diseases such as ALS, otherwise known as Lou Gehrig's disease, and supranuclear palsy. The social conduct disorder is often what we think of with frontal temporal lobe dementia. It's a hallmark sign, and it is particularly troubling for families. Families who are dealing with this with their loved one. For instance, we had a gentleman who had home health coming in, but he was very, very inappropriate with the caregivers. He was watching pornography. It was quite a deal. And what happened, and you can understand why, this family was so embarrassed and so ashamed that they didn't want to engage. They didn't want to get, not purposely, but just because of their shame, it was hard for them to reach out and ask for the help that they needed. Now, one interesting thing about frontal temporal lobe dementia is the absence of a perceptual disorder that is common in other dementias. And I like to tell this story because we utilized it quite effectively with my mom. If there was a door we didn't want her to go out of, we placed a dark or black colored rug right in front of the door. As most dementias progress, their ability to see depth is really quite affected. So a black rug in front of a door looks literally like a hole. And so they will not step on it. And so that's just one example. So with other forms of dementia, curbs, for instance, can be quite challenging. Painted stripes on a gym floor, if they're going to a grandchild's basketball game or something, can really be huge obstacles. They're afraid to step over them because it might be a hole. So that is absent in frontal temporal lobe dementia, which I think is interesting. A sufferer of this will have more apathy rather than depression. So if they have pets, for instance, they may pretty much just completely ignore them. They may have been the center of their life at one point, but now they're ignoring these pets. Dietary changes, often leading to weight gain. They are really known for their repetitive behaviors. And then the latter stages of their disease, they may have a lot of oral exploration. So if you have someone that's eating their hearing aid batteries, partials from a set of dentures or something, that could be an indicator of frontal temporal lobe. Vascular dementia, again, depending on what statistic you look at, is the second or third most common type of dementia. It is compromised of many causes, but strokes are the most common. And we have 2 kinds of strokes: ischemic, which is formed as a clot that forms in one of the blood vessels in the brain, and hemorrhagic, where the blood vessel actually bursts. Other causes include cumulative trauma encephalopathy, as found in football players, boxers, military, etc. Any cause that might lead to hypooxygenation, such as heart attacks, blocked arteries, mini strokes. The onset will often be sudden when large vessels are involved, like in the case of strokes, but they can be much more slowly to develop with smaller vessel disease and injury. Risk factors include obesity, smoking, hypertension, and diabetes. So when people say, are there things I can do to prevent dementia? This is really where we can prevent dementia, is keeping these risk factors low, and it can really reduce your incidence of vascular dementia. Sometimes these can be difficult to quantify due to the numerous potential injuries and causes. Generally speaking, and this is again a generality, and I realize this is a pretty broad brush, but if someone is suffering from vascular dementia, they're probably going to be a little more tearful and anxious than someone with other forms of dementia, which I think is kind of interesting. Just another little thing to put in your Rolodex of things to look for. Medical history here obviously becomes very, very important in identifying vascular dementia. Now, the sudden onset of a stroke or something like that can make this very difficult for families, and denial and family dynamics can certainly be in full display. So we're not physicians necessarily on this meeting today. So what do I do if I suspect someone has a type of dementia? Well, there are 3 different ways that we can go about getting a diagnosis. Many of our internists and even our general practitioners are getting very comfortable with this disease because we've seen more and more of it all the time. So they are often very comfortable starting some medications perhaps in the earlier stages of Alzheimer's. And they're very comfortable, and that's wonderful. And you can certainly go that route. And in fact, it's a wonderful place to start. Others prefer to see, or a physician will make a referral to a neuropsychologist. And a neuropsychologist is a PhD, not an MD, and they specialize in the in the identification of different things going on. And they perform a battery of tests and can usually very successfully not only identify the type of dementia it is, but as well as what stage of dementia that individual is in, and what they would recommend in terms of, does this person need 24-hour care? Does power of attorney need to be invoked? All those kind of things. The third way you can get a diagnosis is through a memory clinic. And this is usually found at larger university medical centers, and is comprised of physicians, neuropsychologists, gerontologists, and they do a very thorough job, not only identifying the type of dementia that it might be, but also ruling out anything else that it could be. As we know, most dementias are a diagnosis of exclusion. So we do need to rule out that there are not other things such as cancer or even severe vitamin deficiencies going on before we adhere to a dementia diagnosis. So now we've got a dementia diagnosis. Now what? And this is where the rubber really meets the road, and really why I wrote the book. Most people who get a dementia diagnosis do one of 2 things. They either go into deep, deep denial, and my father in particular, and he knows this, so I can say it, was one of those. Or they feel like they've been thrown into the deep end of a pool and they don't know how to swim, and it just becomes so very overwhelming. So what do we need to do next? And I talk about this in the book quite a bit. So the first thing is you have got to assemble a village. And if you're working with families with dementia, or whether you yourself are dealing with someone in your life that has dementia, this applies all the way across. So assemble a village. This is not a sprint. This is a disease that can last for years and years. And so you've got to have a close network of people around you that are here to help you and support you. And you may think, well, I don't even know what I would tell them I need at this point. And you're right, you probably don't. So you need to learn as much as you can. And whether it is my book, there are lots of other good books out there that I've read and thoroughly enjoyed, and that we read when we were going through it. Listening to things on YouTube like Teepa Snow, that's usually one of the first places that I send people. And if you've ever been so fortunate as to sit at Teepa Snow's feet and listen to her teach, you know exactly what I'm talking about. So you yourself need to learn as much as you can about the disease. And then you need to help those around you learn, whether that's passing along books, linking them to YouTube videos, or whatever you can do to help your village learn about what your loved one is going through and of what you're going through. And then both you and they will be able, better be able to help you. Get legal affairs in order. And I cannot emphasize how important this is. It's got to start with, if you don't already have it, power of attorney, living wills, all of those things. Yes, they can be done on LegalZoom, or you can get some forms from your nearest Staples or Office Max, but when possible, using a good estate planning attorney is always advisable. And then you've got to think about the future. And this is probably the hardest part, honestly, because you don't want to think about the future. One of the most common phrases I sometimes hear is, well, if it doesn't get any worse than it is right now, we'll be okay. And that's a lovely thought, but all of these diseases are progressive. And as the way they are today is going to be the best they ever are, because it's going to continue to progress and get worse. So making plans or trying to make decisions in a time of crisis, after they've wandered away in a snowstorm, or after there's been a car accident, or something like that, no one makes good decisions in a crisis. So it's really important that you plan for the future ahead of time, when you can make calm and rational decisions. So when the time comes that you need some extra help at home so you can get a break, which you're going to need, even if you don't think so today, you are going to need, who are you going to want to have come in and do that in-home care? If you need at some point to turn to a community-based service, what and who is that going to look like? Are you going to utilize day-stay services? Let's say you're still working and you've got to have a safe place for your loved one to go during the day, or a permanent move-in. You need to start looking at those things well in advance. You don't just want to take the community who has availability on that day. You want to have the best for your loved one. And so you want to look at these things ahead of time. You want to get your names on some wait lists, so that when you do need to pull the trigger, that you are able to do so confidently, knowing that in calmer days, you made those decisions. And then I can't stress this enough. You need to get involved in a support group, whether that is in your church, through a nonprofit. A lot of the communities that provide memory care have support groups. In-home care companies have some support groups, but get involved. I think one of the things we often feel when we're going through something like this is that we're on an island, that we're the only person who's ever had to deal with this, because we become so isolated and so reclusive. And as our person progresses in their stages of dementia, that just becomes more and more all the time. So getting involved in that support group helps us to know that we're not on an island. It's not just us. And we can have that support that is so needed. So at this point, I would really like to open it up for some questions and answers. I will allow Randy to I think he's kind of been going through any questions that have come up, and would like to entertain those. So
great. Great comments, Beth. And again, for those that want the book, just simply send me an email at rbulo@youroasisadvisor.com. Happy to send that along. There was someone also interested, Beth, in your book having a signature or having it signed by you. Is that possible?
Oh, I think we can work something out. I don't know that that's worth a whole lot, but
if somebody wants to have you do that, they can, I assume, just go to your website and connect with you that way. Would that be the easiest?
Yep, or send me an email, text, anything is fine.
Yeah, and your information is on the screen. So if you're interested in a signed copy, you're welcome to contact Beth that way. One of the questions that came up is, Is there a dementia type that fits when one experiences unexpected or inappropriately timed laughter that doesn't match up with the conversation or the situation?
I don't know that there is a particular, I don't know that I can take that and say, oh, it's definitely this. I could definitely see that fitting into a myriad of scenarios. For instance, okay, so in dementia, and this is probably more Alzheimer's, but I think it's all of them to a certain extent. Think of it as this: things are happening around you so fast, you cannot keep up. So imagine you are on a bullet train and you are looking straight out the window, not ahead, not behind, but straight out that window. Would you be able to pick out any of the things going by? No, it'd just be a blur because it's going by so fast. They equate Alzheimer's and different forms of dementia to being kind of like that. So you're trying to catch up or keep up with the conversation or whatever is going on around you, but it's all going so fast you can't. So you may occasionally pick something out, but maybe it's a delayed thing where it was finally something that clicked that maybe was said 20 seconds ago, and now there's laughter. It could also be nervousness or being uncomfortable, and they don't know what else to do, so you just kind of chuckle a little bit. But it could also be frontal temporal lobe, where those, you're just a little more disinhibited and just not quite sure of what's appropriate at that point. So I can kind of see it fitting into a lot of different scenarios. If I had to guess, and this is just purely a guess, I'm not a physician by any means, or a neuropsychologist, I would probably tend to guess it more towards the frontal temporal lobe.
Okay, good. There's a couple of questions on COVID. One, can you please touch on COVID and dementia, suggestions for family members not able to see their loved ones? And then any suggestions on screening home care to avoid COVID-19?
Okay. Well, the first part of that question, I wish I had a good answer for you. Our folks with dementia, they are declining rapidly due to COVID. We do have some communities that have maintained, because it's dementia, maintained very much a community atmosphere while they are all together. So have not done as much social isolation, in the individual rooms that maybe we have seen in assisted living. Some certainly have, but I think they've all recognized that is far more detrimental to someone with dementia. So there's, in many, many cases, been more of an effort to still keep them all together as a community. One thing that I know a lot of families struggle with, like doing a screen time, whether that's a FaceTime chat or Zoom or whatever, is at some point in the dementia journey, particularly in Alzheimer's and in most others, they cannot differentiate what is reality and what is two-dimensional, so to speak. So they see a photo or someone on a screen and they're not sure if that's real or not. And so it can become very, very confusing and overwhelming. I think window chats, when available, are definitely a more preferred way to go about that, especially in the latter stages of the disease where that 2D, 3D thing is kind of lost. But if I had an answer to that I probably could quit my day job and just market that right now, because everyone is crying out for a good solution. And unfortunately, there really isn't one. I hate to say that.
Well, it's frustrating because you're really not sure of what the other person knows or understands, just to your point. My sister relayed recently to me that she went to visit my mom and did a window visit. And in order to communicate through the window, they had to use a phone. And my mom, when they said goodbye, said, "Thanks for calling." um, even though she was right there. So, but she laughed at it. But it's you got to just do the best you can. You have to be creative. But I don't know that there's any community type that suffers worse than memory care during these times, because it's hard enough for them to feel a part of things, and for their family to connect. It's super hard. So
yeah, it breaks my heart every day. It really does. It's an emotional topic for me, because
yeah,
the whole thing is emotional for everybody anyway.
yeah,
This one really, really gets me.
yeah.
And then the other part of that was screening an in-home caregiver for as it relates to COVID, or just screening
As it relates to COVID.
as related to COVID. I think you need to talk to the owner or the manager for that particular company. Ask them what steps they are taking to screen their employees regularly. I think it's okay to ask the person coming to see your elderly loved one, what are you doing in your off time? Are you a university student? If so, that should probably send off a red flag for you because, university students it seems to be sweeping through our university campuses pretty quickly here as of late. So, or are they pretty much keeping to themselves, ordering takeout, not visiting places that, people are deeming to be a little more high risk? But I would start with the owner / manager and see what they're doing. Or, I would hope they're testing their employees regularly.
Yeah, it's a tough one. And we tend to hear about what's going on inside of nursing homes and senior communities, not so much about those receiving care at home. That's, because of the numbers, they don't come in waves, but it's still every bit as risky and perhaps more difficult to control.
Yes.
To your point.
Yeah, absolutely.
Any other questions? Feel free to put them on the chat. Beth, while we're waiting for another question or two, can you talk a little bit more about the book and what people can expect to see in the guide, how you kind of outlined it?
Oh, absolutely. So basically, as I kind of alluded to earlier, I wanted the book to be the guide that I wished we'd had. So it really starts at the beginning of, oh boy, I think there might be something going on with my loved one. I'm not sure, but something's not right here. So starting there, then how do you get a diagnosis? And I kind of touched on that a little bit today. And then once you have a diagnosis, the biggest question is, now what? So restructuring everyday life and what that looks like. How to overcome obstacles. Not every dementia patient is this sweet little old person who just can't remember. These can be very, very challenging situations. Not always, but we often find that however they were before dementia will be amplified in dementia. So if you have an angry individual before dementia, you're going to probably have an angrier individual after the diagnosis and through the coming years. So these situations, they can become very precarious. They can be downright dangerous for the individual providing the care. And that's not even, then we talk too about caregiver stress and what that looks like. There's a study that was done at Ohio State University that showed the stress encountered by a person caring for someone with dementia was akin to someone suffering from post-traumatic stress disorder. And that is in no way to minimize post-traumatic stress disorder. That is a very real and very serious thing. It is to bring attention to truly how stressful it is to care for someone with dementia full time. So we talk a little bit about that. And then we talk a lot about resources. So what is out there that you can utilize? And then at the end, I put in a bunch of questions that you can talk about as a family unit, to maybe even with your loved one that has dementia, depending on where they're at in their journey, so that you can be better prepared for what is inevitably going to come next.
Yeah, it's a great resource, and I really encourage people to get a copy if you don't have other resources in particular. One question reads, my mother passed away recently from CJD, a very rare form and fast-paced type of dementia. Are you noticing this type of dementia on the increase?
Crutchfield-Jakob disease, CJD, is very, very rare. I have run into it one time, and that was a little over a year ago. Unfortunately, our medical community here missed it. I can understand why, to a certain degree. In her case, her hallucinations and delusions, particularly delusions, were very, very intense. And she believed herself to be the Virgin Mary. And so if you have someone who was functioning quite well 6 weeks ago and now is in your ER, claiming to be the Virgin Mary, it's easy to get tunnel vision, and it can be easy to automatically go another route with someone who comes to you like that. When we were asked to come and see her, the thing I couldn't get out of my head was that her physical status was deteriorating as quickly as her mental status. And I said, something's not right here. And we started researching. I started researching. I had a hunch, but needed to research it. And sure enough, I'm like, yeah. So we were able to tell the family based on my research, when you go to back to the ER, ask for these tests. And then obviously a doctor was able to make that diagnosis, but it's very, very rare. I am so sorry that you had to go through that horrific experience. That is intense. Usually
Did you notice an increase in that, Beth?
No,
Have you any evidence?
I haven't personally. I haven't looked at any stats nationwide though. So
probably so rare that it's not well, as in your case, not well diagnosed also. And maybe we're getting better at that. And so it seems to be on the increase, perhaps.
Well, that could be as well. Yeah. Yeah.
Good. Well, we're wrapping up our time here. I want to thank everyone for joining. Again, Beth, thanks. Great job. We got a lot out of it. And again, for anybody that needs any help at all, please reach out to me. You have my email. We're always happy to help in any situation. With that, if Vicki or Lisa is available, I'll turn it back over to you guys.
Looks like they're muted.
Vicki, are you there? Vicki,
I'm here. I'm unmuted. Thank you very much, Randy, Beth, and all that Really appreciate your time. Appreciate the good information you gave. Thank you, Randy, for offering this book, and Beth for writing it and giving people some sound advice as to discover. It is a very sad situation. Sometimes it comes on out of the blue and one doesn't know how to deal with it. Thank you, everybody that attended. And unless, Nancy, do you have anything else to share? Lisa, do you have anything else to share? We can wrap the program up.
Oh, I just wanted to, again, thank you very, very much for your time today. It was awesome. We had a lot of participants, so I'm sure got a lot out of it as well. Feel free to, by the way, check out our new website. We launched a new website about a month ago on seniorsbluebook.com. So I encourage you guys to check that out, including the events calendars. So anybody on the call, check it out.
Yeah, I wanted to mention, or there was a question that just came in too that asked if there's a recording for those who came late. And I think you'd mentioned that, Vicki.
Yes, yes, Lisa has recorded this.
And where can people find it?
Lisa, I'm gonna leave that one to you. And she's muted.
Lisa, you're muted.
You are
Lisa, you're
muted.
muted. There you
Okay,
go.
here we go. Thank you.
There we go.
Actually, this will be on our website at seniorsbluebook.com after it has downloaded and we get that taken care of. And it will also be on our Seniors Blue Book YouTube page. So you'll be able to find it there. So, and I think it will go out probably later this afternoon or tomorrow to those who had RSVP'd. So it will be available for you there as well.
As a link.
Yeah. Thank you
one
so
other
much,
thing-
Beth. It was an absolutely amazing
Really. Yeah.
information, and thank you so much for sharing that with us. And thank you, Randy, for bringing it to
My
our.
pleasure.
Absolutely.
Okay. Good afternoon to one and all, and we'll see you on
We'll
Zoom.
see you shortly at our next SBB University. Please reach out if you have topics you'd like to learn about. Thank you again. Have a great day.
Bye now.